Good day, everyone. Our topic for today is thoracic surgery. I will be giving you a lecture about the diseases inside the thorax that we usually refer to the surgeons. My lecture will be divided into four major parts. So at the end of this video, you will learn about the usual presentations of patients with thoracic surgical diseases. You will also learn about the pathophysiology of these diseases. Then you will know the diagnostic modalities to rule in and rule out each one of them. And finally, I'll give you an outline how to approach this group of patients. Now, before anything else, I would like to give you the general anatomic overview of the thorax. The thorax is made up of these six major important structures, but we will focus on the lungs, the chest wall, and the pleural cavity since the mediastinum and heart will be discussed in cardiovascular module and esophagus is part of the upper GI. These are the common complaints of patients with thoracic problem. Take note that most patients are asymptomatic. A significant number of them presents with shortness of breath, others with cough or hemoptysis. Those patients with inflamed pleura usually complain of pleuritic chest pain. When patients come to you with one or more of these presentations, you have to rule in thoracic diseases. And the best initial diagnostic modality is chest X-ray. To elaborate on this, many of our patients are asymptomatic or having a cough or hemoptysis referred by their attending physician and bringing with them a chest x-ray and a finding usually of a solitary pulmonary nodule. So what will you do? So with the given scenario, we will review the approach to newly diagnosed pulmonary masses on chest x-ray. First and foremost, review the present chest x-ray. And it's very helpful to ask for an old chest x-ray so that you can compare them to determine if there's a significant growth of the nodule. Now, if no change and the mass is benign looking, you can choose to observe. If on the other hand, there's a significant change or even without previous chest x-ray, the nodule is showing high risk for malignancy, request for a CT scan to have a better definition of the mass. That will help you decide if you need to do a biopsy or wait and watch. So now, speaking of risk for malignancy, we will do biopsy if there is a significant risk based on 1. Patient's profile and 2. The mass characteristics. We will do biopsy particularly for patients in the old age bracket, those patients with significant smoking history, and those patients with known history of cancer in the family. We will also do biopsy for those 3 cm masses or bigger, those masses with significant growth for the last 6 months, those masses with speculations, and lastly, those with documented lymphadenopathies on CT scan. There are two approaches for thoracic biopsy depending on the location of the nodule. You can do CT or PET scan guided transthoracic biopsy for peripheral lesions such as the one on the left. For the centrally located masses, like the one on the right, it is safer to do bronchoscopic biopsy. Sometimes, video-assisted thoracoscopic surgery or VATS is done in cases wherein it is not safe to do both, or the surgeon tried several times with non-conclusive results, or those cases with negative lymph nodes on CT scan wherein the surgeon is planning to do a double set of surgery wherein he is planning to remove the lobe of the lung where the mass is located if proven positive for malignancy on frozen section. Granted biopsy was done to your patient. The pulmonary mass will be either be benign or malignant. Majority of them are benign, particularly hamartoma and granuloma. Malignant tumors are either primary or metastasis from other organs, most commonly from breast cancer. Now, if the biopsy result is malignant, the approach is similar with other types of cancers. You confirm with the biopsy, states the disease by doing the metastatic workup. We review back the CT scan, request for bone scan, and liver ultrasound. This is to direct your treatment for either curative or palliative intent. For the primary, we have to remember that there are two main types. Small cell cancer, which account for less than a quarter of all lung primary, and it is not responsive to surgery. Non-small cell cancers, on the other hand, account for the 80%, and they are amenable to surgery in the early and locally advanced stage. So now, let's concentrate on the non-small cell cancers. The management then is based mainly on the stage of the tumor. For stage 1, meaning the cancer is found only in the lung and negative for lymph node spread, the standard is surgical removal, either lobectomy or segmentectomy, and mediastinal lymph node dissection. Radiation and chemotherapy is added depending on the grade of the tumor and the status of the surgical margin. For stage 2, that is the cancer has spread to the lymph nodes in the lung, the management is surgery and chemotherapy. Radiation is added only if the tumor is high grade or the resection margin is positive for cancer. If the cancer has spread to the mediastinal lymph nodes or stage 3, the surgeon should analyze carefully the CT scan for resectability. Most stage 3A are resectable and are therefore amenable to surgery, and both chemotherapy and radiation are added to prevent recurrence. Most stage 3B are non-resectable because of proximity or direct invasion of vital structures such as the heart, great vessels, and major airways. So they are treated by palliative chemotherapy and radiation. Now, if the cancer has spread to distant sites or stage 4, surgery has no role. The standard treatment then is chemotherapy. What if the patient now come to you with shortness of breath? What will you do? For dyspnea, go back to basics. Rule in the common causes of dyspnea. Use the 6 P's of dyspnea. Is it due to pulmonary or bronchial obstruction? Is it due to pleural disease? What about pulmonary embolism? Heart failure? Is it pneumonia or foreign body? Take note that not all causes are surgical. To ascertain the cause, still the best initial diagnostic modality of choice is chest X-ray. So now, what if the X-ray looks like this? First, analyze the chest X-ray. The film shows a wiped out right lung and the trachea is deviated to the right, which means a massive amount of fluid is occupying the right pleura, pushing the mediastinum to the contralateral side. And this is a typical picture of massive pleural effusion. So what will you do? You drain the fluid. So now we will discuss pleural diseases. The two most common diseases of the pleura are pleural effusion, abnormal accumulation of fluid in the pleura, and pneumothorax, abnormal presence of air in the pleura. Speaking of pleural effusion, these are the 7 main causes of effusion. The first two at the top are due to systemic causes and are usually treated medically. The fluid is usually transudate. The rest are due to local causes. The fluid is exudate and they need surgical drainage. The approach for pleural effusion starts by confirming the presence of effusion from the X-ray. The next step is to determine if thoracentesis is needed. We use the 4U's as a guide. What are the 4U's? Unilateral, since most unilateral effusion are caused by local factors. Uncomfortable, the patient is symptomatic, meaning the fluid is massive enough to cause dyspnea, so it needs to be drained. Undiagnosed, especially if you are considering malignancy. And lastly, unresponsive to medical therapy. Even though it is clear that the fluid is transudative, but failure of the medical therapy tells us that there might be infection or a concomitant disease causing the failure of the treatment. Once thoracentesis is done, you have to decide if a chest tube is to be inserted by using the Leitz criteria. These are the components of Leitz criteria. The pleural fluid is an exudate if one or more of the following are met. Thus, chest tube insertion is indicated. Either CTT is done or not, we should determine the cause by sending the specimen we drain for comprehensive analysis of the pleural fluid so that we can arrive at a definitive diagnosis and management. For the complete pleural fluid analysis, we use the mnemonic 4-letter Cs. First C is cell count and differential. Second C is all about chemistry, the glucose, protein, and LDH. Third C is culture. It includes gram stain and culture and sensitivity, AFB and KOH. And lastly, cell block and cytology to rule out malignancy. The last topic I want to discuss is pneumothorax. It is either spontaneous or traumatic. For spontaneous pneumothorax, the prerequisite is a bullae or a bleb, which are balloned out part of the surface of the lungs, which are gradually thinned out through time and then ruptures causing pneumothorax. It is classified by cause as primary or secondary. Primary if there is no identifiable cause. These patients are usually young, healthy, tall, and lanky. Secondary, if the bleb is attributed to an identified pulmonary disease like TB or COPD. Now, for management of pneumothorax, we have to know that pneumothorax is a surgical emergency. If there is a sign of tension pneumothorax, such as deranged vital signs, or there is a deviation of the mediastinum to the contralateral side on chest X-ray, we need to drain the air ASAP. If chest tube is not readily available, we do needle decompression by inserting a large bore IV needle on the second intercostal space, mid-clavicular line, to buy time for the chest tube. Then, once available, chest tube is inserted on the area called triangle of safety, which is bounded by horizontal line crossing the nipple and bisecting lines from the lower tip of the axilla to both posterior and anterior axillary line. I guess that's the end of my lecture. I hope you learned so much from this video, and I'll be glad to answer your questions in the question and answer forum. Thank you so much.